Good afternoon, students. Welcome to my review for our cancer, lymphatic, and immune system review. We're getting towards the end of the semester here. Happy holidays. Yesterday was Thanksgiving. I hope you all were able to spend some quality time with your family, eat some good food, and then get back to studying because we got this test next week, Monday, and then Wednesday and Thursday's class also have this test. So we didn't have a whole lot of time to prepare for it. So I definitely want to do a good job on this review and give you guys what you need to be successful. So just to review, in our book, this test will be on chapters 8, 10, and 11. So chapter 8 is cancer, chapter 10 is the immune system or lymphatic, and then 11 has to do with the immune and lymphatic disorders. So getting right away into this, the last test I was a little concerned because I'm still putting questions on there for looking ahead for our final. There's going to be some review questions on there, and I definitely want to keep hitting on potassium. I noticed that people were still getting some answers wrong, specifically when I talk about using diuretics. Say hi, Luna. Hello. Specifically when we're using diuretics, that definitely will affect your potassium levels. So whenever someone's on diuretics, you want to keep track of their potassium levels. Now, you have to know, of course, what the potassium levels are. What is the normal? And typically, we tend to say about 3.5 to 5. So when you're above 5 on your potassium level, your body is holding on to potassium. It's not releasing it. That can affect your cardiac function if the potassium levels get too high. Conversely, if your body's leaking out too much potassium, letting go of too much potassium, you're below 3.5, that is also a problem too. So know the normal potassium level, 3.5 to 5. Potassium is definitely affected whenever you use diuretics. So getting into cancer, when we talk about cancer, the outcomes are getting better and better now these days with the new advanced treatments. Catching cancer earlier, the earlier you can catch cancer, the better prognosis you have of treating it. So when you catch cancer in the late stages, it's troublesome to treat because if you catch it late, the cancer could spread. It can metastasize to different parts of your body. So you definitely, the earlier you catch that cancer, the better outcome you can have catching it early. But we have to know that not all cancers, when we catch them, even if you do catch them early, there are some kind of cancers that are real aggressive, and even if you catch them early, they can be really difficult to treat. So we definitely have to think about how do we approach the topic of death and dying, especially with our cancer patients. So typically someone who's been newly diagnosed with cancer, I'm sure they're going to go through several stages, and we talked about those in class. Usually it ends up with anger, denial, bargaining, depression, and then finally acceptance. But someone who just found out that they have cancer, if they start crying in front of you, you definitely want to be therapeutic in your communication and have them try and open up to you. So get them to talk to you, get them to expand upon their thoughts and their feelings, and try and help them work through that. So therapeutic communication, someone just diagnosed with cancer, you definitely want to get them to talk more about their feelings. When we talk about, I didn't get to talk too much specifically about colorectal cancer, but just know that people who have the highest risk factors for developing cancer, of course, there's cancer that can be passed on genetically, and then there's cancer that you get later in life due to exposure to certain carcinogenic factors. So when I give you a list of people saying who's most at risk for developing cancer, first thing you should look at is age. We know that as you age, the risk factor for getting cancer goes up. The other factor that you want to look into is what is their job? Have they been exposed to certain chemicals? So are construction workers, are people who work in coal mines or paint factories, um, if there's high pollution around you, or you work in a bar where you can be exposed to alcohol. You know, first of all, people who drink alcohol, of course, substance abuse, smokers, they tend to have a higher risk of developing cancer. So, and then also someone who has a diagnosis already of an autoimmune disorder. So say they already have an autoimmune disorder, they're advancing in age, their environment can expose them to carcinogenic factors. We know that that person would probably be most at risk. So history of autoimmune disease, the external environment, and then of course age. Those are all three important factors that we have to consider when we're talking about developing the risk for cancer. Are people with implanted radiation devices? So I might refer to this as a radiation sealed source modality. I'll also refer to it as an implanted radiation device. That is that little metal device that they implant in somebody who has cancer. They implant it directly into the organ or area or tumor that has the cancer. And then that little metal implant is sealed with chemotoxic medication, and it slowly releases that into the tissue and hopefully kills the cancer cells. The thing with this is someone who has an implanted radiation device, who has a sealed source modality, their body fluids can become toxic to especially our children and our pregnant women. So someone who has an implanted radiation device, we're advising our patients that children and pregnant women should not go near them at all. So if you have family members who are coming in to visit someone who has an implanted radiation device, we have to educate them about keeping their distance and not coming into too close contact with them, because that radiation can actually emanate from their bodies and can actually affect other people around them. So who else is around these patients? Us, the nurses. So we definitely have to try and limit our time that we spend with these patients. So does that mean you go in there, rush, and make them feel like, you know, they're something less than human? Well, that's a fine line. You know, you have to find the balance between I got to get in here, do what I have to do, and then get out, but then also being able to meet this patient's need. These patients with radiation device, it's only temporary, but I can only imagine that after a week, couple weeks, a month or two, and people, whenever they see you, especially your healthcare providers and your family, whenever they come near you, they're like, hey, I can't get too close to you. So that's got to be tough. But the other thing is, people with implanted radiation devices, if you see that radiation device come dislodged, or you see just laying somewhere, you can't just pick it up with your bare hands. We would advise that you put gloves on and get a forceps to grab it, and then we put it in the appropriate place. You'd have to call your facility's infection control manager or supervisor and see where exactly they want you to put that. Some people talk about a lead-lined container. I don't know that I've ever saw one of those at my work, but I never really asked or I never dealt with someone who had an implant. So the other thing is that their body fluids, you want to protect yourself always with personal protective equipment. You don't want to be touching their body fluids, because their body fluids can secrete this chemotoxic medication, and if you get it on yourself or something, that can affect your own genetic DNA. So you definitely want to wear gloves when handling body fluids. Some facilities tell you to flush twice when you're dumping their urine or any body fluids. So those are all important things. What else? Luna, I need this. So I talked about developing cancer. Oh no, we kind of talked about that. What else? Okay, let's talk a little bit about the difference between benign growths and malignant growths. Malignant means that the original source of the neoplasm has traveled through the body. It can easily cancer can easily spread. So when they say that your cancer is malignant, that is bad. Versus benign, when I talk about benign, I kind of gave you the example of the little, I think it's a tumor that I have on my arm here. I don't know if you can see that, but it's right here. It's not painful. It's surrounded by like fibrous tissue. It's kind of encapsulated. And so that helps prevent the cancer or the abnormal cells from spreading to the rest of my body. So this is a benign tumor. The chances of it spreading extremely low because it is surrounded and protected by that fibrous tissue, that encapsulation. And the tumor can actually grow bigger. Sometimes this grows bigger and smaller. However, though, it's very unlikely that it'll grow and spread to different parts of your body. So when we're talking about someone who's getting radiation therapy, that is that little beam that's directed towards the cancer area. Sometimes that can kind of affect your skin, so we want to teach people good skin care. And we don't necessarily want to apply scented lotions or really lotions of any sort. We don't want to shave their chest. We don't want to keep that area covered. What we do want to do is wash that area gently with a mild soap and water that's not too cold and not too hot. So someone who's getting radiation therapy to a certain part of their body, we want to teach them to care for it by washing gently with mild soap and tepid water. When I talk about someone who's getting radiation therapy for Hodgkins lymphoma, remember with Hodgkins, the difference between Hodgkins lymphoma and non-Hodgkins lymphoma is the presence of Reed-Sternberg cells. And in Hodgkin's lymphoma, there are the presence of Reed-Sternberg cells. When you catch Hodgkin's lymphoma early, it does have a pretty high rate of getting it out of there and becoming cured from it. So if you had to choose between Hodgkin's and non-Hodgkin's, you want to get Hodgkin's lymphoma. It's more easily treatable and more predictable versus non-Hodgkin's, which doesn't have Reed-Sternberg cells, a little more difficult to treat because it's unpredictable and it grows very aggressively. So what do we want to do? Someone who's receiving radiation therapy along with chemotherapy, we tend to suppress their bone marrow. And when we're suppressing someone's bone marrow, what is that doing to the immune system? Within our bones, inside the middle of our bones is where our blood cells are made. So that's red blood cells, white blood cells, platelets. Those all tend to be made inside the bone marrow or somehow made from the thymus gland. When someone has bone marrow suppression, they are at risk for getting sicker from opportunistic infections. Their body can't fight infections as well. So one of the main primary goals for people who are receiving radiation is to prevent infection. And so what does that mean? We're teaching them to wash their hands, have good hand hygiene. We're teaching them to avoid crowds, heavily crowded areas. We're teaching them to recognize signs and symptoms of infection. And for someone who has a suppressed immune system, they might not show those typical signs of infection, fever, redness, swelling. So we really got to be diligent about teaching them what to expect and what to look out for, and to report to us, the nurses or the healthcare provider, changes in their normal daily life. So with radiation and chemotherapy, someone who's getting that, the goal is to prevent them from getting another infection. Also with chemotherapy, sometimes when they do chemotherapy, it causes mouth sores. So someone who's getting these mouth sores from chemotherapy, we definitely want to promote great oral hygiene. So these mouth sores, when you have an open sore in your mouth, if you don't have good oral hygiene, you can actually get an infection through that sore in your mouth and get sicker. So we want to definitely teach them to do frequent oral hygiene. So that's rinsing, brushing, swishing. And for our people who have bone marrow suppression, remember their platelets are decreased. We want to teach them to use a soft bristled toothbrush so that we don't cause any bleeding to their gums or so our people with also our people who are getting radiation and chemotherapy treatments, it affects their energy levels. They are going to have fatigue. So some of the things that we definitely want to do is teach them how to balance their rest with activity. And they kind of have to prioritize what they're going to do with their energy that on those days where they're feeling really fatigued. I can only imagine getting chemotherapy and radiation, coming home the next day, and all you want to do is lay in bed, and you probably have a million things on your mind, a million errands to do. So it's good for us to teach these patients that they should schedule extra time within their day to allow for errands, because they can become fatigued very quickly. So don't overwhelm yourself. Give yourself extra time in your schedule to complete the tasks that you prioritize and balance that rest with activity. When we're looking at health risk assessment for laryngeal cancer, we definitely want to explore with the patient what is their lifestyle. Are they a drinker? Are they a smoker? Have they had a job where they've been exposed to hazardous material such as asbestos, things like that, radiation? Are they a construction worker? Are they outside for 8 hours a day during the summer? So we definitely want to teach them they have a risk for developing skin cancer. So definitely use sunscreen for our construction workers to help prevent, hopefully, cancer from developing on their skin. When we're talking about immunocompromised patients, of course, I said we have people who develop disorders, they're born with it or they acquire it, where their immune system becomes compromised or dysfunctional. People who are on radiation and chemotherapy, that will compromise the immune system. Using long-term steroids, so glucocorticoids, things like that, corticosteroids. When you're on long-term steroids, that can also affect your immune system and make you immune compromised. And also, of course, are people who have HIV. When you get HIV, that messes with your CD4 T helper cells, and that can lead you to become immunocompromised. So know those things. What else can cause suppression of the immune system? So I talked about steroids, viral infections, smoking, and then your diet and lifestyle. So if you're not eating the right foods, not getting the right nutrients, that can definitely suppress your immune system. So what is the normal, good to know the normal count for white blood cells. When you have a white blood cell count under 4,000, that person definitely is at risk for becoming immunocompromised too, because the less white blood cells you have in your body, the less ability your body has to fight off infection. So someone who has a low white blood cell count, we want to put them in protective isolation precautions. So that means people coming into their private room have to wear a mask. If this patient comes out of the room, the patient is putting on a mask. And we don't want to allow them to eat raw fruits or vegetables because there can be bacteria on those that can affect them. And then also fresh cut flowers. And I didn't get to mention that in class, but fresh cut flowers, we do not allow those in the room of our people who have a compromised immune system or have low white blood cell counts, because there can actually be bacteria or something crazy on those flowers, a mold or something, or who knows what, a yeast. But do not let fresh cut flowers in the room either. When we're still talking about immune deficiency, when we're looking at risk factors, we definitely want to ask the patient about their family history. Did anyone in your family have an immune disorder? We definitely know that age plays a factor. The older you get, the more immunocompromised your immune system becomes. We definitely want to know their weight. Have you lost a lot of weight recently? We want to know about your substance abuse, so alcohol, smoking, drugs, any medications they're on, and have they ever been exposed to HIV? So yeah, like I said again, when we're teaching our immune deficient clients, one of the most important things to include in the teaching plan is teaching them how to wash their hands appropriately, use the right amount of friction, soap, water, and then do it frequently. You know, wash your hands before you eat, after you eat, before you go to the bathroom, after you go to the bathroom. Whenever you're touching things, you want to wash your hands afterwards. Getting a little more into HIV. Now, people who are positive with HIV, these people may be living with family members at their home. So we definitely want to teach the family members of positive HIV clients that they should be wearing gloves when they're doing household chores, because we know that HIV can be spread through body fluids. So that can include saliva, blood, tears, semen, possibly urine. So we want to teach the family members of positive HIV clients that they should be wearing gloves during household chores. When we're teaching safe sex practice, we definitely want to include in our teaching the use of a condom. If you use a spermicide, that does not help. That helps prevent pregnancy, but that does not help prevent STDs or transmission of HIV. So spermicide is not something you would include for safe sex practice. That would be more something for trying to reduce the chances of getting pregnant. Of course, we know the only reliable and 100% proof way of being safe, a safe sex practice, is actually to practice abstinence. That is the only 100% way of making sure that you do not get an STD. So abstinence, that is the only 100% way of not getting an STD. If I would say something along the lines of getting an HIV vaccine, just know that they have, here in America, we have not okayed or allowed any HIV vaccines to be put on the market. From a world standpoint, I think that there are several HIV vaccines that are in development. However, in America, nothing has been approved yet for a reliable HIV vaccine. The problem is that HIV is constantly mutating and changing. So the medicine that they thought 10 years ago would be effective at getting rid of the HIV virus, the virus has mutated, it's changed. So now that drug isn't effective anymore. So trying to develop a vaccine that will protect against all these different strains of HIV, that's very difficult. It's still not approved in America. So that is not, the HIV vaccine is not something you would include in your teaching of safe sex practices. The other thing that you do want to include in your safe sex practice education is to avoid unprotected oral and genital sex. So They do make, I believe, tongue condoms for oral sex because you can get, it is possible to transmit HIV through oral sex. So try and protect your mouth with those tongue condoms. When we're talking about, so anytime that you're giving care to an AIDS patient, if you're using a needle with them, one of the things when you're done poking the AIDS patient with a needle is you never want to attempt to recap the needle. You never want to try and put that cap back on. A lot of the needles that I used in my practice, it has a safety mechanism that when you're done with the needle, you just flick it and then something comes up and protects the tip of that needle so that you don't poke yourself. The main thing is that you never want to recap with the original cap. And then you'd also want to place that needle and syringe in a puncture-resistant container. So never recap after injecting an AIDS patient with a needle. And you really don't want to recap off of anyone. When, as nurses, when we're dealing with our patients, we are taught to assume that everyone has a blood-borne disease. So that doesn't mean we go around telling them that we're treating them as if they have a blood-borne disease. What this practice does is it protects us, because sometimes people who develop HIV or some blood-borne disease, they may not know that they even have it yet. And if they come into the hospital, they don't know they have it. It's not documented on their record that they have a blood-borne disease. As good nurses, we should be treating everyone the same. So what that means is we use our personal protective equipment at all times whenever coming into contact with a patient's body fluids. So what that does for us is that means we don't have to treat people with HIV and AIDS differently, because we should be treating all of our patients as if they have an unknown blood-borne disease, and we're using our diligent protective personal equipment and never exposing ourselves to blood or possibly contaminated body fluids. So people who do have AIDS, they definitely tend to be more at risk for developing infections from opportunistic infections. Are people with AIDS and HIV, their immune system is compromised. So now things that normally don't affect them can cause an infection in them. And one of the things that people with AIDS, kind of common for them to develop as their AIDS progresses, is the Kaposi sarcoma. And that's actually malignant growth on their skin. It's those dark spots. I showed you guys a picture of that in our books. Basically, that's like a skin cancer. So that's quite common or it's one of the more common things that our people with AIDS can develop, is that Kaposi sarcoma. So we're getting through here. Know that when we're measuring a reliable indicator of lymphocytes in the patient with an HIV infection, we want to look at those T helper cells, the CD4 cells. And when the CD4 cells get below 200 and the presence of an opportunistic infection is there, we now consider them to have AIDS. So just know that also when your CD4 levels start to drop below 400 or drop below 500, 400, if they're below 400, you're definitely starting to become immune compromised. So for our people, also our people with HIV, they tend to start to lose weight if their disease starts to progress. So we definitely, to counteract their weight loss, we want to teach them to eat nutrient-dense foods. Fortified protein shakes can help them to stop some of the weight loss, maybe help them gain some of the weight back. You definitely want to have them eating foods that they hopefully like. So if they can combine foods that they like along with nutrient-dense foods and maybe find a good tasting protein shake, that can definitely be a good intervention for our HIV patients who are losing weight. When we talk about lupus, so systemic lupus erythematosus, SLE, also known as just lupus, there's some important things that we should include in their teaching plan. And one of the things that we want to teach them is, remember with lupus, it can affect all of the body systems. One of the more common body systems that it affects is the skin. So you'll see like the trademark hallmark of lupus is this red butterfly rash that appears on their face. They can get very dry skin. So we definitely want to teach them to use, when going outdoors, they're very sensitive to sunlight. We want to teach them to use a sunblock with at least an SPF of 30 or greater. So we want to teach them good skin care, protect your skin, and then also we teach them to use lotions that are fragrant free, because remember, lupus is an autoimmune disorder where the body's attacking itself. And if you introduce a lotion that may have a complex fragrance in it, that can actually irritate the skin more. So we want to teach them, use a fragrance-free lotion at least twice a day. And by hopefully giving them good skincare, remember your skin is your first protective barrier against infections or foreign antigens. So the better we teach them to take care of their skin, the less chances they'll have of getting an infection through the skin. Are people who are allergic to bee stings, we definitely want to teach some priority nursing interventions. So people who are allergic to bug bites or bee stings, someone who is allergic to a bee sting, when they get stung, that area is going to swell up fast. They might get some itching. So one of the first signs of an allergy to either a bee insect bite or a medication is you'll notice their skin may become red, rashy-like. They may start to get some itching. If it's not taken care of and reversed quickly, that can lead to swelling of the internal structures, specifically to do with the respiratory system. So someone who has an allergy and that allergy is triggered, one of the first signs is swelling, redness, and if that is not taken care of, someone who's stung by a bee, you definitely want to look inside their mouth and make sure that their tongue isn't swelling, and you want to listen for stridor. Someone who may be highly allergic to a bee sting, what can happen is their tongue can swell up, and that can cause them to go into respiratory distress. Stridor is inflammation inside the lungs. Now the lungs are swelling up. Stridor is an indication that their allergic reaction is compounding and it's getting worse. And if it's not taken care of soon, they can basically go into respiratory distress. So very important on that. When I talk about immunity, remember I talked about passive immunity, innate immunity, acquired immunity. Those are all very important. So the one with talking about the mom who breastfeeds her baby, that is passive natural immunity. The baby gets a temporary boost from the mother's antibodies and allows the baby to fight infection a lot more effectively when they get the breast milk. So that is passive natural immunity. Passive immunity, that only lasts, that's time limited. That can only, that'll only work for maybe a couple weeks, a couple months. it just gives a temporary immunity from disease. Also, when we talk about passive artificial immunity, that is the administration of immunoglobulins. Immunoglobulins are not a vaccine, they're not an immunization. So immunoglobulins, that is under passive artificial immunity. That is what we give someone who's having an autoimmune disorder, and we're trying to slow that reaction down so that there's not further tissue damage. And when we administer immunoglobulins, we categorize that as passive artificial immunity. When we're looking at artificial immunity, active artificial immunity, that is where we get into the vaccines, the immunizations. When we talk about active acquired immunity, that is where you had the disease, you beat the disease, and now you have immunity to that disease. So that is wrapping up here. One of the last things I want to talk about is when you administer a live vaccination to a patient in a clinic, when you're giving a live virus to them, a live virus immunization, you're administering a live virus to them, they can actually become a carrier. It's not a big enough dose to provoke a full immune response, but it provokes the immune response enough so that we get immunized against it. However, if someone tells you that they have a family member at their home who is on chemotherapy, we do not want to give this person a live virus immunization, because what can happen is we give them the live immunization, they can go home, they have a loved one who's on chemotherapy. The person who's on chemotherapy can actually become, their immune system is compromised, and you can actually give them the live virus that you were just immunized against. So that's kind of important to know about that. When we talk about our patients, as they start to die, specifically people with cancer, as they start to die, we definitely want to know one of the signs and symptoms, or some of the signs and symptoms, that death is imminent. And if someone is on hospice or palliative care, we're trying to give them comfort and ease the process of dying. We're not trying to cure them, we're trying to make them comfortable. But if you have family members coming up to you asking you, when's grandma gonna die? When's grandpa gonna die? Can you tell us? We really can't predict when they're gonna die. I've seen people who they thought they were gonna die in a week, 6 months later, they're still alive. However, what you can look at is some of the signs and symptoms as their disease progresses. And as the body starts to shut down, their breathing can become irregular. They can have what we call the death rattle, and it's basically a buildup of like mucus in their throat. And as they're breathing, it'll be noisy. So they're kind of like, basically they're so out of it, they're dying, they can't clear their own secretions. That's the death rattle. So we can educate the family members of a dying patient that I can't tell you when they're going to die, but I can look at the signs and symptoms. And if I notice that their breathing becomes irregular, noisy, we hear that death rattle, their skin might have changes, they'll have cold, clammy skin. So as the body starts to shut down, it's not the blood isn't circulating as much. Oxygen and fluids can't reach the tissues anymore. So you might notice what we call mottling, and that is where their skin starts to take on like a grayish, almost mixture of like gray and blue color. So those are all signs that we can tell. Also, the blood pressure and the pulse will decrease. That's what we can tell those family members who are just, they want to know when their family member is going to die. And like I said, we can't always predict that. What we can look at is the signs and symptoms. So if the family member does die and some siblings or other family members have come in, they can be very distraught by the news. We definitely want to encourage them to verbalize their feelings, and then we offer support for them through the chaplain, social services, or allow them to have time with the body. When someone dies, there's really no rush to hurry up, bag the body, and get them out of there. If there are family members who are on the way, they're on the plane, they're driving, we're just gonna clean the body and then allow family members to spend as much time as they need with the body so that they can say their goodbyes. So that's about it. There are, I think, 2 or 3 math questions on here, so definitely bring your calculators. I hope this review was helpful for you. I look forward to people hopefully doing well on this test. Like I said, I know we didn't get a whole lot of time to study in between. It seems like we had test 3 and then test 4 right away, and then in 2 weeks we'll have the final. So congratulations on making it this far. I'll see you guys next week. Good luck on the test. And with that, 안녕하세요. Bye.